Are you ready to face the toughest pediatric Nclex questions that separate real nurses from the rest? In this video, we're diving deep into 50 of the most challenging pediatric questions, the kind that test not just your memory, but your critical thinking, prioritization, and clinical judgment. Each question comes with a clear rationale and test-taking strategy, so you'll understand why the correct answer is correct, and how to never miss it again on exam day. So grab your notebook, stay till the end, because the last 5 questions are the ones most candidates get wrong, and they might be the ones that decide your passing score. Question 1. A 6-month-old infant with bronchiolitis is admitted with tachypnea, nasal flaring, and intercostal retractions. Which action should the nurse take first? A. Administer an antipyretic for fever. B. Suction the nares with a bulb syringe. C. Start 4 antibiotics. D. Place the infant in a supine position and feed by bottle. Answer, B. Rationale: infants are obligate nose breathers, nasal secretions impair breathing. Clearing the nares often relieves respiratory distress quickly. Antibiotics are not indicated for viral bronchiolitis. Strategy: always address airway first, ABC relieve obstruction before meds or feeding. Question 2. A 4-year-old with suspected intussusception has sudden onset severe abdominal pain, vomiting, and current jelly stools. Which diagnostic/therapeutic intervention is most likely indicated? A. Barium enema. B. Air contrast, pneumatic, enema under fluoroscopy. C. CT abdomen with contrast. D. Immediate exploratory laparotomy. Answer, B. Rationale: pneumatic, air, enema is both diagnostic and therapeutic for non-perforated intussusception and is preferred over barium due to safety and efficacy. Strategy: for classic intussusception presentation, select the least invasive intervention that is both diagnostic and therapeutic. Question 3. A toddler with suspected dehydration after gastroenteritis has dry mucous membranes, sunken eyes, and decreased urine output. Which oral rehydration plan is best? A. Unlimited clear liquids as tolerated. B. 10 ml per kilogram every 5 minutes of oral rehydration solution, ORS, until rehydrated. C. 100 ml per kilogram over 4 hours of ORS for severe dehydration. D. No oral fluids, start 4 fluids immediately. Answer, B. Rationale: small, frequent volumes, e.g., 5 to 10 ml every few minutes, help restore volume and are tolerated better in vomiting/dehydration. Severe dehydration warrants 4 fluids, but moderate cases begin with ORS. Strategy: for pediatric dehydration with vomiting, choose small frequent ORS amounts rather than large boluses, unless severe signs require 4 fluids. Question 4. A 3-year-old receives an MMR vaccine. Which parental statement requires correction? A. My child may have a fever and rash after this vaccine. B. This vaccine contains live attenuated viruses. C. My child should avoid all dairy products for 48 hours. D. We may see mild joint pain in older children after vaccination. Answer, C. Rationale: there is no dairy restriction after MMR. A and B and D are true. MMR is live attenuated and may cause transient fever/rash. Older children/adults may have arthralgia. Strategy: no common vaccine facts and typical side effects, spot statements unrelated to vaccine guidance. Question 5. A 10-month-old with iron deficiency anemia is prescribed ferrous sulfate. Which teaching point is most important? A. Give with milk to improve absorption. B. Expect stools to turn green or black. C. Stop the supplement once the hemoglobin normalizes. D. Give the supplement with orange juice or vitamin C source. Answer, D. Rationale: vitamin C enhances non-heme iron absorption. Milk inhibits iron absorption. Black/green stools are expected, but the most important to improve efficacy is take with vitamin C. Continue therapy for months after hemoglobin normalizes to replete stores. Strategy: pick interventions that improve absorption/efficacy, avoid choices that reduce absorption. Question 6. A 2-week-old newborn shows marked jitteriness and high-pitched cry. Mother has a history of heroin use during pregnancy. What is the nurse's priority? A. Administer phenobarbital immediately. B. Assess for other signs of neonatal abstinence syndrome, NAS. C. Discharge home with substance abuse referral. D. Offer breastfeeding without restrictions. Answer, B. Rationale: jitteriness/high-pitched cry are possible NAS signs. Assess full withdrawal scoring, Finnegan, and vitals to guide pharmacologic therapy. Breastfeeding may be encouraged in some cases but depends on maternal status. Strategy: with potential NAS, complete assessment/scoring before starting meds or making discharge decisions. Question 7. A 7-year-old with newly diagnosed type 1 diabetes is learning to dose insulin. Which sign suggests hypoglycemia that requires immediate treatment? A. Fruity breath odor and polyuria. B. Diaphoresis, tremors, and pallor. C. Polyphagia and polydipsia. D. Kussmaul respirations and lethargy. Answer, B. Rationale: sweating, tremors, pallor indicate sympathetic activation, acute hypoglycemia. Fruity breath and Kussmaul respirations suggest hyperglycemia/DKA. Strategy: no key distinguishing signs of hypo versus hyperglycemia for rapid management selection. Question 8. A 9-year-old with sickle cell crisis has severe pain. Which analgesic approach is best? A. For NSAID as sole therapy until pain subsides. B. For morphine titrated to pain relief and scheduled PCA if older and appropriate. C. Oral acetaminophen every 6 hours only. D. Withhold opioids to avoid addiction, use distraction only. Answer, B. Rationale: severe sickle pain requires potent opioids titrated to effect. PCA can be appropriate for older children. NSAID/acetaminophen are adjuncts. Avoid undertreating pain. Strategy: for acute severe pain and chronic disease, choose adequate opioid analgesia and multimodal strategy. Question 9. A school-age child with asthma uses an albuterol inhaler and a corticosteroid inhaler. Which instruction is correct? A. Use the steroid inhaler first, then albuterol. B. Rinse mouth after using the steroid inhaler. C. Use albuterol every 4 to 6 hours as maintenance therapy. D. Stop steroid inhaler once albuterol controls symptoms. Answer, B. Rationale: rinsing reduces oral thrush risk after inhaled corticosteroids. For acute relief, albuterol is used first to open airways, then steroid for control. Steroids are not stopped if controller therapy is needed. Strategy: no inhaler sequencing, bronchodilator first for acute relief, rinse after steroid use. Question 10. A 2-month-old presents with 39 degrees Celsius 102.2 degrees Fahrenheit fever and a bulging anterior fontanelle. What is the nurse's best immediate action? A. Give acetaminophen and observe at home. B. Obtain blood cultures, start 4 antibiotics, and prepare for lumbar puncture. C. Encourage fluids and schedule follow-up. D. Apply cool compresses and send home. Answer, B. Rationale: fever with bulging fontanelle suggests possible meningitis/serious infection. Prompt workup and empiric 4 antibiotics are indicated in infants. Strategy: for infants with signs of central nervous system infection, prioritize diagnostics and empiric treatment. Question 11. A child with cystic fibrosis, CF, is having difficulty gaining weight. Which intervention will most improve nutritional status? A. Low-fat diet to prevent pancreatitis. B. Pancreatic enzyme replacement with meals and high-calorie diet. C. Avoiding salt in diet to prevent fluid retention. D. Restricting protein intake to reduce metabolic demand. Answer, B. Rationale: CF causes pancreatic insufficiency. Pancreatic enzymes with meals and a high-calorie, high-fat diet improve weight gain. Salt may be increased, not restricted. Strategy: match therapy to underlying pathophysiology, enzyme replacement for pancreatic insufficiency. Question 12. A 5-year-old with Kawasaki disease is admitted with fever, conjunctivitis, and strawberry tongue. Which intervention reduces the risk of coronary artery aneurysm? A. High-dose aspirin and 4-immunoglobulin, IVIG, early in the illness. B. Broad-spectrum antibiotics and steroids. C. Anticoagulation with warfarin during acute phase. D. Low-dose aspirin only after fever resolves. Answer, A. Rationale: early high-dose aspirin and IVIG within 10 days reduce coronary complications. Antibiotics are not indicated unless bacterial infection. Strategy: for Kawasaki, early IVIG plus aspirin is standard to prevent coronary involvement. Question 13. An infant with suspected congenital hip dysplasia shows asymmetric thigh folds and limited abduction of the left hip. Which is the next best step? A. Reassure the parents, this resolves spontaneously. B. Perform the Ortolani/Barlow maneuvers and arrange for ultrasonography. C. Plaster casting immediately. D. Wait until walking age to reassess. Answer, B. Rationale: clinical exam maneuvers, Ortolani/Barlow, and ultrasound are appropriate in infants 6 months for diagnosis. Early diagnosis is crucial for non-surgical management, Pavlik harness. Strategy: abnormal neonatal hip findings require immediate exam maneuvers and imaging, don't delay. Question 14. A 7-year-old with acute lymphoblastic leukemia, ALL, is receiving chemotherapy and develops fever of 38.5 degrees Celsius 101.3 degrees Fahrenheit. ANC is 300 cells/L. Which action is highest priority? A. Administer acetaminophen and observe. B. Obtain blood cultures and start broad-spectrum 4 antibiotics promptly. C. Schedule a CT scan to look for infection. D. Delay antibiotics until culture results return. Answer, B. Rationale: febrile neutropenia, ANC less than 500, is a medical emergency, obtain cultures and start empiric broad-spectrum 4 antibiotics promptly. Strategy: for immunocompromised patients with fever, act quickly, empiric antibiotics before waiting on cultures. Question 15. A 9-year-old with acute otitis media is prescribed amoxicillin. Parent reports the child had a maculopapular rash after amoxicillin previously. What should the nurse do? A. Give the medication, mild rashes are not a contraindication. B. Withhold medication and consult provider for alternative antibiotic. C. Administer epinephrine before next dose. D. Substitute ibuprofen instead. Answer, B. Rationale: a prior rash to amoxicillin suggests possible allergy, provider should be consulted and alternative antibiotic used. Do not give penicillin-class meds if allergy suspected. Strategy: any history suggestive of drug allergy requires reassessment and provider notification before administration. Question 16. A 2-year-old with lead poisoning has a blood lead level of 48 G/dl. Which intervention is indicated? A. Start oral chelation with PGIMER, DMSA, per protocol. B. No intervention, repeat level in 6 months. C. Begin iron supplementation only. D. Immediate whole blood transfusion. Answer, A. Rationale: lead levels greater than or equal to 45 G/dl generally warrant chelation therapy, PGIMER, in children per usual protocols, along with environmental removal. Strategy: recognize level thresholds that trigger chelation and combine medical therapy with environmental interventions. Question 17. A 4-year-old with potential foreign body aspiration has sudden coughing and unilateral decreased breath sounds. Which is the best next step? A. Heimlich maneuver immediately for conscious child. B. Obtain a chest X-ray and schedule bronchoscopy urgently. C. Start 4 antibiotics. D. Administer nebulized albuterol. Answer, B. If child is stable and coughing effectively. A. If child is choking and unable to cough or breathe. Rationale: distinguish between an effective cough, allow observation/diagnostics, and complete airway obstruction, emergency maneuver. Unilateral decreased sounds warrant imaging and bronchoscopy. Strategy: triage airway emergencies, If ineffective cough/airway compromise immediate maneuvers, if stable but suspicious imaging and bronchoscopy. Question 18. A 6-month-old with failure to thrive weighs below the 3rd percentile. Which initial intervention should the nurse prioritize? A. Evaluate caregiver feeding technique and caloric intake. B. Start tube feeding immediately. C. Order genetic testing. D. Arrange for psychiatric evaluation of parents. Answer: A. Rationale: most initial steps include detailed feeding history, observation of feeding technique, and caloric assessment. More invasive testing/tube feeding considered after assessment. Strategy: start with the least invasive assessment that may reveal correctable problems. Question 19. A 3-year-old with hemophilia A sustains a laceration. Which immediate action is most appropriate? A. Apply direct pressure and administer factor VIII concentrate per protocol. B. Use tourniquet and send home with ice. C. Give aspirin for pain control. D. Apply heat to promote clotting. Answer: A. Rationale: hemophilia A patients require factor VIII replacement for significant bleeding plus standard measures, direct pressure. Avoid aspirin, antiplatelet. Strategy: for coagulation disorders, replace deficient factor per protocol and avoid medications that worsen bleeding. Question 20. A neonate of a diabetic mother exhibits jitteriness and apnea in first hours of life. Which is the highest priority assessment/action? A. Check blood glucose and treat hypoglycemia promptly. B. Start 4 antibiotics for presumed sepsis. C. Swaddle and observe. D. Give oral glucose gel only. Answer: A. Rationale: infants of diabetic mothers are at high risk of hypoglycemia causing jitteriness/apnea. Immediate blood glucose check and treatment, for dextrose if needed, is priority. Strategy: with symptomatic neonates and risk factors, IDM, verify glucose first before other causes. Question 21. A 5-year-old with severe dehydration becomes lethargic and has delayed capillary refill. What 4 fluid and rate are appropriate initial management? A. 20 ml per kilogram isotonic crystalloid bolus, normal saline, for rapidly. B. 10 ml per kilogram D5W over 1 hour. C. 100 ml per kilogram of hypotonic fluid in 24 hours. D. Start peripheral TPN immediately. Answer: A. Rationale: for signs of shock or severe dehydration, give isotonic fluid bolus, 20 ml per kilogram NS, rapidly, reassess. Hypotonic solutions and D5W are inappropriate for initial resuscitation. Strategy: when perfusion is compromised, pick isotonic bolus therapy per pediatric resuscitation guidelines. Question 22. A 12-year-old with suspected appendicitis has periumbilical pain migrating to the right lower quadrant, fever, and elevated WBC. Which diagnostic step is best? A. Immediate appendectomy without imaging. B. Ultrasound first, if inconclusive, CT abdomen with contrast. C. MRI is contraindicated. D. Reassure and observe at home. Answer: B. Rationale: ultrasound is preferred initial imaging in children to reduce radiation, CT if ultrasound inconclusive. Immediate surgery might be considered if signs of rupture or peritonitis. Strategy: minimize radiation in pediatric imaging, ultrasound first when possible. Question 23. A 2-year-old with severe eczema has intense pruritus interfering with sleep. Which topical therapy is recommended for moderate to severe flares? A. High-potency topical corticosteroid applied to affected areas under guidance. B. Daily bleach baths only. C. Oral systemic steroids long-term. D. Apply topical antibacterial ointment to all skin. Answer: A. Rationale: topical corticosteroids, appropriate potency for area/age, are first line for moderate flares. Systemic steroids have risks long-term. Bleach baths and emollients are adjuncts. Strategy: for flares use topical steroids per severity and age, use adjunct skin care measures. Question 24. A 15-year-old female with suspected anorexia nervosa has BMI less than 17 and bradycardia, HR 38. Which is priority? A. Immediate hospitalization for medical stabilization. B. Start outpatient psychotherapy only. C. Provide a calorie counting plan and discharge. D. Refer to family counseling and wait. Answer, A. Rationale: severe bradycardia and low BMI indicate medical instability. Inpatient medical stabilization is required due to risk of arrhythmia, electrolyte disturbances. Strategy: medical instability and eating disorders requires inpatient care before outpatient therapy. Question 25. A child with acute otitis externa is treated with topical antibiotic drops. Which instruction is most important? A. Keep your canal dry and complete full course of drops. B. Use cotton swabs to remove debris after each dose. C. Avoid swimming for 2 weeks only if pain persists. D. Systemic antibiotics are always necessary. Answer, A. Rationale: keeping the canal dry and finishing topical therapy are key to resolving otitis externa. Cotton swabs can worsen the condition. Systemic antibiotics usually not necessary unless cellulitis. Strategy: emphasize local care and completion of topical therapy for external ear infections. Question 26. A 10-year-old presents with petechiae, ecchymoses, and gum bleeding. Platelet count is 15,000/mm superscript 3. Which immediate intervention is indicated? A. Consult hematology and prepare for platelet transfusion if bleeding or count very low. B. Give aspirin for pain and inflammation. C. Schedule routine follow-up in 1 week. D. Start warfarin therapy. Answer, A. Rationale: severe thrombocytopenia, less than or equal to 20,000, with bleeding risk may require platelet transfusion and urgent hematology evaluation. Aspirin is contraindicated. Strategy: low platelets with bleeding signs require urgent action and specialist consultation. If you're enjoying this video so far, like and subscribe. Welcome back. Question 27. A 1-year-old with pertussis, whooping cough, is admitted. Which nursing intervention reduces transmission risk? A. Place the child in droplet precautions and give macrolide antibiotic to close contacts. B. No isolation needed once antibiotics are started. C. Use negative pressure airborne isolation room only. D. Only symptomatic treatment is necessary for family. Answer, A. Rationale: pertussis spreads via droplets, droplet precautions and macrolide prophylaxis for close contacts are appropriate. Airborne isolation is not required. Strategy: match isolation precautions to transmission mode and prophylax close contacts when warranted. Question 28. A 14-year-old with new-onset focal seizure has MRI showing a solitary cortical mass suspected low-grade tumor. Which is the most appropriate next step? A. Refer for neurosurgical evaluation for resection. B. Start high-dose steroids and observe. C. Begin broad-spectrum antibiotics. D. Discharge with anti-seizure meds only. Answer, A. Rationale: solitary resectable cortical mass causing seizures often requires neurosurgical evaluation for excision and histopathology. Anti-seizure meds manage seizures, but definitive management often surgical. Strategy: identify lesions that are surgically treatable and involve appropriate specialties early. Question 29. A child with severe allergic reaction has stridor, hypotension, and urticaria. What is the immediate medication and route? A. Intramuscular epinephrine, 0.01 mg per kilogram, max 0.3 to 0.5 mg, into the lateral thigh. B. For diphenhydramine only. C. Inhaled bronchodilator only. D. Oral antihistamine and observe. Answer, A. Rationale: anaphylaxis requires IM epinephrine immediately. Antihistamines and bronchodilators are adjuncts, not substitutes. Strategy: for anaphylaxis, give epinephrine IM right away, don't delay. Question 30. A 7-year-old with ADHD is prescribed methylphenidate. Which instruction should the nurse include? A. Administer the medication in the morning to reduce insomnia. B. Expect weight gain as a common side effect. C. Abruptly stop the medication if behavior worsens. D. Take with a heavy meal to improve absorption. Answer: A. Rationale: CNS stimulants can cause insomnia. Dosing in the morning and possibly extended-release formulations help. They can cause appetite suppression/weight loss, not gain. Tapering may be recommended rather than abrupt stop if needed. Strategy: choose timing and monitor growth and sleep when teaching about stimulants. Question 31. A child with coarctation of the aorta shows higher BP in the arms than the legs and weak femoral pulses. Which immediate management is indicated in symptomatic neonate? A. Start prostaglandin E1, alprostadil, to maintain ductal patency. B. Immediate correction with diuretics only. C. No intervention until older. D. Start long-term ACE inhibitors at home. Answer: A. Rationale: critical coarctation in neonates may depend on ductus arteriosus patency. Prostaglandin E1 opens the ductus and stabilizes circulation before definitive repair. Strategy: in ductal-dependent lesions, use prostaglandin to stabilize blood flow before surgery. Question 32. A 13-year-old with suspected rheumatic fever has migratory arthritis and subcutaneous nodules. Which lab test supports the diagnosis? A. Elevated antistreptolysin O, ASO, titer and elevated ESR/CRP. B. Positive ANA test only. C. Low WBC with neutropenia. D. Elevated blood lead level. Answer: A. Rationale: recent group of strep infection markers, ASO, plus elevated inflammatory markers support rheumatic fever diagnosis. ANA is for lupus, not specific here. Strategy: for suspected post-streptococcal complications, identify antibodies and inflammatory markers consistent with recent infection. Question 33. A preterm infant, 28 weeks, on oxygen develops increasing oxygen needs and bilateral ground glass chest X-ray. Which diagnosis is likely and what prevention reduces risk? A. Respiratory distress syndrome, administer antenatal corticosteroids to mother and exogenous surfactant to infant. B. TTN, transient tachypnea of the newborn, give diuretics. C. Bronchiolitis, give bronchodilators. D. Meconium aspiration syndrome, intubate and suction routinely. Answer: A. Rationale: preterm infants lack surfactant causing RDS. Antenatal steroids and surfactant therapy reduce incidence/severity. TTN is more in term infants, meconium aspiration in term/post-term infants. Strategy: match typical radiographic and gestational age findings to the correct neonatal respiratory disorder. Question 34. A 2-year-old with suspected hypertrophic pyloric stenosis presents with projectile non-bilious vomiting and an olive-like mass in RUQ. Which lab abnormality is most typical? A. Hypochloremic, hypokalemic metabolic alkalosis. B. Metabolic acidosis with low bicarbonate. C. Hyperglycemia and elevated ketones. D. Hyponatremic hyperkalemic metabolic acidosis. Answer: A. Rationale: repeated vomiting causes loss of HCl and fluid hypochloremic, hypokalemic metabolic alkalosis. Correct electrolytes before pyloromyotomy. Strategy: link vomiting patterns to expected electrolyte disturbances and prioritize correction pre-op. Question 35. A 6-year-old with suspected bacterial meningitis is febrile and lethargic. Which empiric antibiotic choice is appropriate pending cultures? A. For ceftriaxone plus vancomycin, age/weight appropriate dosing. B. Oral amoxicillin only. C. Topical antibiotics. D. No antibiotics until lumbar puncture results return. Answer: A. Rationale: empiric 4 broad-spectrum antibiotics covering common pathogens, ceftriaxone/vancomycin, should be started promptly after cultures in suspected meningitis. Delay increases morbidity. Strategy: for serious suspected bacterial infections, begin empiric IV therapy promptly after obtaining cultures. Question 36. A 5-year-old has newly diagnosed juvenile idiopathic arthritis with morning stiffness and limited range of motion. Which treatment principle is foundational? A. Early physical therapy and NSAIDs, consider disease-modifying agents if needed. B. Strict bed rest until inflammation resolves. C. Avoid NSAIDs in children. D. Surgical joint fusion immediately. Answer, A. Rationale, early mobility, PT, and NSAIDs control symptoms. DMARDs like methotrexate are considered for persistent disease. Rest and surgery are not first line. Strategy, preserve joint function with early mobilization and appropriate pharmacotherapy. Question 37. A 3-year-old presents with a febrile seizure lasting 4 minutes and returns to baseline. Which is appropriate after recovery? A. No anticonvulsant prophylaxis is routinely indicated for simple febrile seizures. Provide antipyretic and education. B. Start long-term anticonvulsants immediately. C. Admit for continuous EEG monitoring in all cases. D. Perform lumbar puncture in all children with febrile seizure. Answer, A. Rationale, simple febrile seizures less than 15 minutes with full recovery do not require long-term anticonvulsants. Evaluate for source of fever, LP indicated if meningitis suspected, e.g., meningeal signs. Strategy, differentiate simple versus complex febrile seizures to guide management. Question 38. A neonate with bilious vomiting and abdominal distension in the first 24 hours of life is suspected to have intestinal obstruction. Which is the most urgent next diagnostic step? A. Obtain plain abdominal X-rays, upright and decubitus, and consult surgery. B. Begin oral feeds immediately. C. Start stool softeners. D. Schedule outpatient barium swallow. Answer, A. Rationale, bilious vomiting in neonate is surgical until proven otherwise, obtain abdominal X-rays and surgical consult promptly. Do not feed until obstruction ruled out. Strategy, treat bilious neonatal vomiting as potential surgical emergency, imaging and consult come first. Question 39. A 16-year-old presents with primary amenorrhea. Secondary sexual characteristics are present but uterus is absent on pelvic ultrasound. What is the likely diagnosis to consider? A. Mayer-Rokitansky-Kusterhauser, MRKH, syndrome, Müllerian agenesis. B. Turner syndrome. C. Androgen insensitivity with breast development should show a blind vaginal pouch and undescended testes, consider but ultrasound may not show uterus. D. Pregnancy. Answer, A, and consider complete evaluation including karyotype and endocrine tests to differentiate. Rationale, MRKH presents with normal secondary sexual characteristics, ovarian function intact, but congenital absence of uterus/vagina. Karyotype and further evaluation distinguish from androgen insensitivity. Strategy, for amenorrhea, match presence/absence of secondary sex characteristics and imaging findings to likely etiologies and plan further tests. Question 40. A child with febrile illness develops a petechial rash and hypotension rapidly over hours. Which organism is classically associated with this fulminant picture and requires immediate public health consideration? A. Neisseria meningitidis, meningococcemia. B. Streptococcus pyogenes. C. Respiratory syncytial virus. D. Coxsackie Answer, A. Rationale, meningococcemia can present with rapid fever, petechiae/purpura, and septic shock, immediate antibiotics and public health measures, prophylaxis for close contacts, are indicated. Strategy, recognize fulminant septic presentations that require emergent antibiotics and contact tracing. Question 41. A 2-month-old infant who was formula-fed presents with projectile vomiting and olive-like mass, suspect pyloric stenosis. What is the most appropriate diagnostic test? A. Abdominal ultrasound to measure pyloric muscle thickness and channel length. B. Upper GI series only. C. CT abdomen. D. Stool culture. Answer, A. Rationale: ultrasound is the preferred diagnostic test for hypertrophic pyloric stenosis in infants. Upper GI is secondary. Strategy: choose non-invasive imaging appropriate to the age and suspected condition. Question 42. A child suspected of having Duchenne muscular dystrophy presents with Gowers' sign and calf pseudohypertrophy. What genetic test confirms diagnosis? A. Genetic testing for dystrophin gene mutation, deletion/duplication analysis. B. Muscle biopsy only, no genetic testing available. C. Serum ammonia level. D. EEG. Answer: A. Rationale: DMD is confirmed via genetic testing of the dystrophin gene. CK is usually elevated and muscle biopsy reserved if genetic testing inconclusive. Strategy: for suspected inherited neuromuscular disorders, genetic testing is first-line diagnostic. Question 43. A 3-year-old with urinary tract infection has a urine culture positive for E. coli. What imaging is recommended to evaluate for vesicoureteral reflux, VUR? Avoiding cystourethrogram, VCUG, after first febrile UTI in some guidelines, or after recurrent UTIs, renal ultrasound often done first. B. Immediate CT urogram. C. MRI abdomen. D. No imaging is necessary. Answer: A. Renal ultrasound often first, VCUG indicated based on age, severity, recurrence per guidelines. Rationale: VCUG is diagnostic for VUR, imaging strategy depends on age and UTI characteristics. Discuss specific guideline thresholds with provider. Strategy: know that febrile UTIs in young children prompt imaging, choose renal US and VCUG per recommended algorithms. Question 44. A 9-year-old with inflammatory bowel disease, Crohn's, is being started on corticosteroids for a flare. What is an important short-term teaching point? A. Monitor for hyperglycemia, mood changes, and increased appetite, avoid abrupt stopping. B. Expect immediate cure and stop other meds. C. Steroids cause permanent growth acceleration. D. No infection risk while on steroids. Answer: A. Rationale: steroids have metabolic and psychiatric side effects and immunosuppression. Do not stop abruptly and monitor side effects. Long-term use affects growth negatively. Strategy: teach about side effects and taper plans when initiating systemic steroids. Question 45. A 15-year-old with severe acne is started on isotretinoin. Which counseling point is essential? A. Strict pregnancy prevention program, 2 forms of contraception, baseline and monthly pregnancy tests for females, and monitoring for depression/suicidality. B. No special monitoring required. C. It's safe during pregnancy. D. Over-the-counter vitamins are unnecessary. Answer: A. Rationale: isotretinoin is highly teratogenic, rigorous pregnancy prevention and monitoring are mandatory, monitor mood changes. Strategy: for teratogenic meds, prioritize reproductive counseling and mental health monitoring. Question 46. A 4-year-old with febrile illness develops a positive rapid strep test and is started on penicillin. Which complication is the antibiotic therapy intended to prevent? A. Acute rheumatic fever. B. Appendicitis. C. Otitis externa. D. Juvenile idiopathic arthritis. Answer: A. Rationale: treating group A strep pharyngitis with antibiotics reduces risk of acute rheumatic fever and peritonsillar abscess. Strategy: link specific antibiotic treatments to their main complications they prevent. Question 47. A 7-year-old with acute epiglottitis, drooling, tripoding, muffled voice, arrives. What is the most important immediate nursing action? A. Ensure airway is secure, do not attempt throat exam or agitate the child, prepare for intubation in controlled setting. B. Visual inspection of the throat with a tongue depressor. C. Give PO antibiotics immediately. D. Encourage child to lie supine for exam. Answer: A. Rationale: epiglottitis can cause sudden airway obstruction. Avoid agitating the child or examining the throat. Secure airway in controlled environment with anesthesia/ENT. Strategy: with suspected airway compromise, prioritize airway and avoid maneuvers that may precipitate complete obstruction. Question 48. A neonate has positive newborn screen for medium-chain acyl-CoA dehydrogenase deficiency, CAD. What dietary advice is essential? A. Avoid prolonged fasting and ensure regular feeding. Emergency protocols for illness to prevent hypoglycemia. B. High-fat fasting diets recommended. C. No special precautions are needed. D. Restrict carbohydrates entirely. Answer: A. Rationale: CAD inability to oxidize medium-chain fats leads to hypoketotic hypoglycemia during fasting/stress. Avoid prolonged fasting and have emergency glucose plans. Strategy: for inborn errors of metabolism, focus on prevention of metabolic decompensation, feeding schedules, sick day plans. Question 49. A 11-year-old with clinical signs of severe dehydration is receiving 4 fluids. The RN is calculating maintenance and deficit for rehydration. Which principle applies? A. Use isotonic fluids, NS or LR, for initial resuscitation and correct deficits over 24 hours with appropriate maintenance plus deficit replacement, adjusting for ongoing losses. B. Use hypotonic fluids initially. C. Give dextrose-containing solution as first bolus. D. Replace all deficits with oral fluids only. Answer: A. Rationale: isotonic crystalloids are used for resuscitation. Calculate maintenance plus deficit and replace over recommended time while monitoring electrolytes. Dextrose may be added later per needs. Strategy: for pediatric fluid calculations, separate resuscitation boluses from maintenance and deficit replacement, and always reassess frequently. Question 50. A 6-month-old with suspected pertussis is treated with azithromycin. What advice should be given to household contacts? A. Close contacts, regardless of immunization, should receive macrolide prophylaxis, especially infants and pregnant women in 3rd trimester. B. Only symptomatic contacts need treatment. C. Prophylaxis is unnecessary if vaccinated. D. Use amoxicillin for prophylaxis. Answer: A. Rationale: macrolide prophylaxis for close contacts reduces spread. Certain populations need particular protection. Vaccination history does not eliminate need for prophylaxis in exposures. Strategy: for contagious respiratory infections, prophylaxis for close contacts may be recommended regardless of symptoms or immunization status. If you made it this far, you're already steps ahead of most NCLEX candidates, because consistency and critical thinking are what make a nurse stand out. Which question challenged you the most? Drop your answer in the comments. I'll be replying personally to help you master it. Don't forget to subscribe, turn on the notification bell, and check out my next video on NCLEX prioritization and delegation, where we'll break down real exam-style scenarios that could appear on your test. Until then, keep studying smart, keep believing, and remember, you're not just preparing to pass the NCLEX, you're preparing to save lives.